Let's begin. Hello, and welcome. I'm Eric Wargotz, President of MedChi, and I'm your moderator today. And we are I am pleased to announce our sponsor is Unity Insurance, and Ron Kendall is here with us. He's the Executive Vice President of Unity, and he will place his contact information in the Q&A section of Zoom, and he is available to speak with you on how you can save money with the same levels of insurance or even better that you have now. And he's looking forward to hearing from you. So thank you, Unity. Thank you, Ron. I appreciate it. Okay, well, welcome to part 2 of Good Nutrition, Good Health, and How to Get There, the Management of Chronic Disease. And let me introduce our panelists for today. We have Dr. Aruna Nathan. She is an expert in lifestyle medicine, emphasizing chronic disease management and prevention through balanced lifestyle elements and in particular, better nutrition. She is the immediate past president of Montgomery County Medical Society in Maryland. Welcome, Dr. Nathan. And we have Dr. Neil Barnard. Dr. Barnard has been relentless in his organization's PCRM in the promotion of a plant-based diet towards managing and preventing a number of chronic diseases. And he promotes this approach in a team effort through continuous research, education, and outreach medical center. He is also a colleague of mine on the adjunct faculty at the George Washington University School of Medicine. Welcome, Dr. Barnard. It's a pleasure to have you.
Thank you, Dr.
Mr.
Ward.
Arthur is Dr. Harris's senior legislative aide. And as a team, he and the congressman continue as fierce advocates of improving federal nutritional requirements for the SNAP program and the education and promotion of better nutrition in the participating population in order to avoid the progression and development of chronic disease. Congressman Dr. Harris is chairman of the House Appropriations Subcommittee on Agriculture, Rural Development, Food and Drug Administration related agencies, where Mr. Arthur assists him with his discussions and information there. So there we have it. Let's move on. So what I wanted to do is just briefly recap part 1. Part 1 occurred on October 25th, 2025, and I just thought I'd bring into view a little of what was discussed there. And the topic of nutrition and health, as you can imagine, really extends back into ancient times. And here I'm highlighting Egyptian civilization, but it's around the world. Folks in those ancient civilizations understood that there was some relation of what you eat to how you survive, your health during life. In ancient Egypt, there's food documentation as medicine 6,000 years ago. The Ebers Papyrus is the early medical records detailing food-based cures. And what we're doing today is we want to move to the modern transition, moving from avoiding disease to, which is what we discussed in part 1 in October, to actively managing it or even reversing it with every meal. So we're going to continue to discuss these topics. Please. So this is the issue. It's money, and it's obviously related to health. You can look on the right. We've got from 1920 to 2026, a century of rising costs. It's a future we cannot afford to ignore. So you can look at the numbers, 47 trillion projection over the next 15 years for health costs. So how can we try to get that down, right? Reduce that through good measure. And so it's an economic burden of chronic disease primarily. We have diet-related chronic diseases drive nearly 90% of the annual U.S. health care spending. Total annual health expenditures, we mentioned 4.1 trillion. And I'm sorry, the projection is what we mentioned earlier. Chronic disease could cost the U.S. 47 trillion over the next 15 years. So let's take a closer look at that. So the physician knowledge gap. Doctors as the conduit in our training as physicians, MDs and DOs, we get maybe 1% nutrition education, 99% other aspects of medicine. And you can see historically less than 1% total lecture hours. We've got medical students receive an average of only 1.2 to 1.9 hours of formal nutritional education annually. 75% of US medical schools require no clinical nutrition classes as 2024, but there are changes coming. We're all going to talk about that in a couple of minutes. But will it matter? And the answer is absolutely. The future of our health depends on it. So let's take a look. So this is where we're going to bring in the panelists because we want to talk a little about where we're going with this. With federal mandates from HHS, mandates and, of course, very forceful encouragement, more than 50 medical schools have committed to increase nutritional training. But what are they going to teach? That's the big question. We all have maybe different understandings or opinions on what healthy nutrition is. So the future of medical education, this is a turning point, but it's for patient health care, patient outcomes, and the future of medicine. So let's talk about this shift, Dr. Nathan. Why don't you lead us off? How do you see this? I'm sure you look at it as an advancement is helpful, but I'm sure perhaps you can shed some light on what your understanding is of what might be taught and what you think ought to be taught.
So, as you said, Eric, there are more close to 50 medical schools now that they have committed to adding nutrition training. And this is extremely important, as you pointed out, because so much of chronic medical conditions are affected by foods and nutrition. But it's not just important to have that knowledge and recognizing that nutrition plays a big role. We really need to train the future doctors to act on it. Or what do you do with that? And I think there are multiple ways this can be brought about. Definitely more of an immersive experience where they learn the skills to work with people in a sensitive and in a manner that is culturally relevant, and also in a very team-based manner, because you really want to empower the dietitians, the registered nutritionists, and the dietitians, and you want to work towards this issue as a team. And this kind of collaborative care can also be brought about in the medical school education. So preparing the future doctors, not just with the scientific evidence-based knowledge, but actually even teaching them the fine skills on how to use this practically in clinical experience.
Thank you. Dr. Barnard, your take on this, and also the role, I know in your office, and perhaps in Dr. Nathan's as well, you employ and you refer, maybe you don't employ, but you still use dietitians and nutritionists, and we're going to come back to you, Dr. Nathan, on that after Dr. Barnard responds. But how do you envision, are they losing their jobs? Do they still have a role? What are your thoughts about all of this?
Well, I think you've touched on what's really such an important issue is getting nutrition to become an integral part of medical care. But there are really three things that the doctor has to know about. They don't have to be an expert in every aspect of nutrition any more than they have to be an expert in every aspect of radiology, psychiatry, endocrinology, if that's not their specialty. But they do have to know three things. Number one, what are the conditions where nutrition matters? So nutrition matters a lot in cardiovascular disease, needless to say, getting cholesterol down. It matters in cancer, both prevention and in survival after diagnosis. It matters in diabetes, both type 2 and type 1. It matters in hypertension. It matters in obesity, obviously. So we can't just go off and write our prescriptions for a GLP-1. Foods are essential to all of this. So that's number one. Know where nutrition matters. Secondly, you have to know what kind of diet that you want to order for the patient. You don't have to necessarily be the one to fill the prescription. You don't have to be teaching your patient for an hour. But in the same way as if you have a hospital patient, which patients need a low sodium diet and for what reason? You have to know that for your outpatients too. We have put these diets to the test, as you mentioned, and we have looked at, say, a Mediterranean diet We've looked at vegan diets. We've looked at low carbohydrate diets, and we've come to strongly to the conclusion that Mediterranean diets are inappropriate for anyone who wants to lose weight or to get their lipids improved. They just don't, although they are often better than the diets people came in on, they're not enough better to move the needle on those things. Low carbohydrate diets and low calorie diets are difficult for a number of reasons, and that's why we get into the plant-based diets as the ones that are most effective and most sustainable. So that's number two, is to know which diets to order. And number three is know to whom to refer. You have to not only refer to a dietitian, that's the analogy of, say, the orthopedic surgeon who refers to the physical therapist. That's the person who's going to do the work for you. The registered
Right.
dietitian is going to do that, but they have to be an expert also in the diet that you are going to prescribe.
I appreciate that. And we're going to get to really uniform definitions and how important they are when you talk about whole foods and healthy nutritions and healthy nutrition. Yes, Dr. Nathan, please. The role
Thank
of this the allied health professionals with this
So,
movement to educate physicians on
sh-
more
I
on
think,
nutrition.
yes, I think that you need to definitely have a team-based approach. But we're not going to have that in every situation. So but there are many physicians who are struggling to help patients with nutrition, and they don't have the time within their, practice settings to do that. And I think for that reason, adopting some of the other practices like shared medical appointments, using immersive techniques like teaching kitchens, and contracting with dietitians, um, play a big role. So it's not one thing that's going to work, one formula that's going to work for all different clinical situations. We really need to be thinking out of the box, and we want to make these changes or these recommendations as culturally sensitive as possible, because only then you'll have longitudinal value for a wide range of patients or people.
Very good. Well, as a transition to the next slide, the question I want to ask all of you, and Mr. Arthur, lead off with you because it has to do with some policy. And I realize that nobody has really been talking about this lately that I'm aware of. So we talk about a lot about educating the consumer. And, by educating physicians, we're educating also consumers and the patients they see. But what about the manufacturer? Should we be looking at health impact fees on ultra-processed foods, food companies to help fund medical training, and SNAP incentives that we're discussing today? Is that something that you and the congressman have discussed? Anything you can share with us on that?
Yes, absolutely. I mean, these are a lot of ongoing conversations right now. In fact, and believe it or not, there's actually been a lot of bipartisan conversations on this. So, for example, in one of the most recent appropriation bill markups that occurred earlier this year, maybe a couple of weeks ago, Congresswoman Debbie Wasserman Schultz proposed an amendment to the bill to talk about how the Federal Trade Commission can look at how some of these food producers and manufacturers are marketing their products for a variety of individuals, including children. And Congressman Harris expressed interest in that. So we are working in a bipartisan manner with Democrats to figure out ways to address this. And no, it's definitely rewarding. There's a lot of ongoing conversations right now. I also want to circle back to something that was mentioned earlier by Dr. Nathan about the importance of definition. So we need to have a clear and concise definition as to what is ultra processed foods, for example. And there's been a lot of good progress being made with the FDA in partnership with HHS and NIH to come up with what the terms are and what the definition is. So that way, when we do draft policy and regulations and rules, we have a clear and concise way to go about it. So it's important to have a full team effort in regards to this. So that way we understand what we are talking about. So that way there isn't any confusion, that way we're all on the same page in regards to teaching, future physicians, future providers about the importance of nutrition and general medical education, how they can relay that information over to patients who may have questions or concerns, and then take all that information and put into a treatment.
Thank you very much. Let's move on. That's very helpful. We all appreciate that. So reversing the narrative, how do we get from disease to health? So you can look on the right side of your screen, you can see before, current for a lot of folks, poor diet, poor control, your blood sugar spikes and crashes. I think we've all heard a lot about inflammation, how the inflammatory response really fuels a lot of this chronic disease. and it leads to fatigue and low energy, increased medication needs. We'd love to get people off medication, right, doctors, and greater risk of complications. And then afterwards, what we're seeing, and we're going to lead off with Dr. Barnard in a minute, reduced inflammation, sustained energy, lower or eliminated medications, lower risk of complications. So, again, I introduced Dr. Barnard earlier, but I do want to highlight his NIH-funded research, really groundbreaking. I don't think I'm exaggerating, on using diet, a specific diet, to reduce or even eliminate type 2 diabetes in some folks. Why don't you tell us a little about your experience, Dr. Barnard, and then we'll move on to Dr. Nathan with the same question.
Sure. Our approach with type 2 diabetes, I have to say, for me personally, it was kind of earth-shattering, really. My father was the diabetes expert for Fargo, North Dakota, where I grew up. I never once heard him say that anyone ever got better. It was sort of a slow decline. But our approach to this disease changed the minute we were able to look inside the cells that are becoming insulin resistant. And we discovered that they're filled with accumulated lipid, which was astounding. The liver cells and the muscle cells that need to take in glucose, that pull the sugar out of the blood, they're filled with fat, basically. And the insulin can't work anymore. So instead of reducing carbohydrate or wagging a finger about sugar, we made the choice to try to get the fat out of the cells. And to do that, we got the fat out of the diet. And this is what NIH funded us to do 20 years ago. And it just completely revolutionized diabetes treatment. What we did is we did not change or try to influence caloric intake. We didn't try to influence carbohydrate intake. What we did is we took the animal products out, so there's no animal fat, limited vegetable oils, and that allows about a third of liver fat to exit within about 16 weeks, and insulin sensitivity returns if people get dramatically better. And Dr. Wargotz, you mentioned inflammation, which is such a key. Inflammatory markers like high sensitivity CRP improve so fast. I know Dr. Nathan has seen this too, where you see the patients getting better. It's not just their diabetes. Other parts of their lives are getting better too. So it's been very rewarding for the patients and certainly for the caregivers too.
Well, that's a great transition to Dr. Nathan. Dr. Nathan, so we've talked about diabetes. I know you have experience there as well, but maybe you can enlighten us with, in your practice, seeing patients day in and day out, one-on-one, heart disease, hypertension, memory, fatty liver, obesity, and more. What are you doing, and are you seeing the changes one might anticipate based on what we know about good nutrition today?
Oh, most definitely, yes. Because, once you see what nutrition and diet changes can do, you cannot unsee it. Like Dr. Barnard mentioned, the first time I saw patients coming off diabetes medications and, having normal hemoglobin A1Cs after going for years with high levels and on multiple medications, you cannot unsee that. That makes you really change how you practice medicine. And when the way we approach, so the way I personally approach medical care is I try to first, just understand where the patient is coming from, right? Like most of us, and then trying to get to what they want to accomplish. Now, when I was in private practice, patients who came to me, they came to me to come off medicines. A lot of them knew that I was a lifestyle medicine physician, and they came with that intention, and they were ready to work in a very fast-paced way to come off, change their diets. Where I work now, most of them don't even recognize me as a lifestyle medicine physician or a plant-based physician. They're coming to me as an internal medicine physician, and then when I introduce these concepts, it's still new to them, but they still want exactly the same thing. And so I do exactly what I did before in my private practice here. And we are seeing patients coming off medications. But the first thing I have to say is when they come, the first thing they do is start actually taking their medicines, because as we know, 50% of the patients don't really take medicines, or we don't take medicines as we are prescribed. And that is, we have stats behind that. So the first thing they do is start taking their medicine. So we have to be aware that, oh, they're going to take all these medicines all at once. Their blood pressure is going to drop, their sugars are going to drop, because many of them have gone for months without actually taking half those medicines. But then when they start making these dietary changes, over time, you can see them coming off medicines. And then for heart disease, especially, and for kidney disease now, we still continue to leave them on a few medicines, which are guideline-based therapy, but they come off most of the other medicines.
Well, thank you. That's insightful, both of you. Thank both of you. So some of your favorite foods are listed are illustrated under before. And then hopefully some of your new favorite foods are shown under the after side of the graph. I want you to pay attention to that. And I think the food as medicine model, reducing pharmaceutical reliance through whole foods is really important. And as you both have expressed, and the evidence is clear, the food isn't just fuel, it's medicine, and we can change the trajectories, and we can change lives. And let me just also present, we showed the money at the beginning. I don't think anyone here on this panel talking live today has the focus on the money. We focus on the people. We care about people. We want to see people live productive, happy, healthy lives, as long as we can get them there and they can pitch in and help themselves to do so. The money is important because the government cares about how much is going in to each and every one of us, the care and the health of each and every one of us. And that's why that's so important to illustrate. If we can get that money down, then it shows that we've improved health outcomes, and the government is going to want to cut less. That's the belief, right, Mr. Arthur?
Yes, absolutely. I mean, it's important to make sure. Yeah.
You want to make sure you're agreeing to something that's appropriate. So SNAP is a clinical tool. So realigning policy with science. You can see SNAP households currently spend roughly 20% of benefits on sweetened drinks, desserts, and candy. The average benefit per person is only $187 per month. The opportunity here is to produce prescriptions, right? And healthy food incentives to replace survival calories from junk food and processed and ultra processed foods. And it's really interesting because we know that Dr. Harris has been vocal about the fiscal cost of diet-related illness. Regarding the legislative process, we're trying to understand, why is it so difficult to align our SNAP spending with clinical reality that certain unhealthy calories are costing taxpayers trillions in long-term health care, Mr. Arthur?
Yes, no, absolutely. And one thing I want to point out is recently there was a fantastic political article that came out that was highlighting this exact issue. And I would say that the main reason why there hasn't really been as much progress being made in aligning these priorities is because of lobbying. According to the political article, the food and beverage industry has spent a record $113 million in lobbying efforts since January of last year, which is projected to be a 30% increase compared to their spending in 2024 and 2025. For example, Mars and Hershey spent almost half a million dollars on their lobbying efforts in the first quarter of this year alone. The National Confectioners Association put in another $250,000. The American Beverage Association spent nearly $1 million in the first 3 months of this year. And then Coca-Cola and Pepsi spent about an additional $1.8 to $2 million in addition to that. So there's a big lobbying effort to try to keep this in, because 10% to 20% of all benefits spent go to sweetened beverages, sugary snacks, salty snacks, and stuff along those lines. So there's an economic and profit incentive for these companies and these organizations to want to keep the status quo, because they are getting a hefty payout at the end of the day. So, for example, last year, the SNAP received almost $100 billion in funding. So 10% of that, they're still getting almost $1 billion in total for additional profits. So they want to keep things the status quo.
No, I understand that. And so we'll consider ourselves well-meaning folks, physicians, and other consumers. How do we address that? And how do you all address it on Capitol Hill as a policy? You need the money. It's understood. You need the money for reelections and this and that. There's a lot of interests, a lot of special interests. I think Dr. Harris has stuck his neck out several times and continues to do so to offer restrictions from the federal level on the use of SNAP funds. So how are you all dealing with this pressure?
Yeah, no, absolutely. And I mean, I would say that the thing we have to do is just be consistent and keep talking about it, keep mentioning it, keep, releasing op-eds and, going to the press and talking about this in real time and highlighting the concerns on this. And one thing I would say over the last couple of years, I would say the culture surrounding food has definitely shifted towards our direction where food as medicine is becoming a calling card and being more, talked about at kitchen tables has become, I would say, a daily, conversation at this point. And obviously, things don't happen overnight. So I would say the main thing is just being consistent, talking about it. And thankfully, like I mentioned, the paradigm has shifted, I would say, in our direction in regards to what we're trying to do. And we just got to keep moving forward with it. And one thing I want to note is we're not saying we want to ban, Coca-Cola or Pepsi or McDonald's or anything along those lines. No, that's not the point we're getting at. The point we're getting at is that the SNAP, the Supplemental Nutrition Assistance Program, it was designed to provide a nutrition assistance to low income and people who are in need of assistance. We want to get back to the cause of that because year after year after year, the top three items purchased on SNAP are soda, candy, cakes and salty snacks and all that stuff. And there's no real nutritional value with this. So we want to get back to what the science is and the needs. We want to make sure that SNAP goes back to nutrition.
Right. And then so that's, the issue is how do we reconcile our national health policy from the financial interests of the lobbies? And it's very challenging. I'm not asking you to to be able to answer that today. We all know the challenges involved in that. Let's move on, Dr. Nathan. The Is it a nanny state overreach to restrict SNAP funds for being used for ultra processed foods, or is it a clinical necessity to save our healthcare system from fiscal collapse? I know it's sort of a
I
policy question. I wanted to get your
Yeah,
thoughts and your Dr. Barnard's thoughts on that.
I I I I have mixed, I definitely have mixed opinions about that. I think that it can be viewed a little bit as reactive if we were to just address the 20% that is spent by the SNAP recipients. I think that might create some changes in market at the local level. I think incentivizing foods that are healthy, like vegetables and fruits, and also not just having produced, but pre-made healthy meals that are available for SNAP recipients, because there's also lack of time for many of the SNAP recipients because they are working 2 or 3 jobs to cook these meals. Um, I would approach it in that manner.
Okay.
Definitely, there is a lot behind this. It is not like a simple problem, right? There's so many
Right.
facets to it. But I would think of it in a more structural, stepwise manner.
Thank you. And Dr. Barnard, I'll repeat the question if you'd like. Is it a nanny state overreach to restrict SNAP funds from being used for ultra processed foods, or is it a clinical necessity to save our healthcare system from fiscal collapse?
It's a clinical necessity, not only fiscally, but also for the health of our patients and the children that grow up in the household. And I want to say a word of thank you to Matthew for what your office has done to speak up on this. It's so important. Um, Every food assistance program has restrictions. It's not just free food. If you go into a school lunch, they are not going to serve just anything that a child might want to have as a snack. It's carefully planned by federal policy. Now, the policies may or may not be good, but there are restrictions there. Same with the WIC program. The SNAP program should be the same. And in 2017, we published in the American Journal of Preventive Medicine a seminal article that we called Healthy Staples. And the idea is this: what if, instead of saying, buy anything you want to with this card, what if we said, let's supplement, let's give away for free as part of SNAP the healthy staples that keep people healthy, the foods that you'd be proud to give to somebody who is in need. And that's fruits, it's vegetables, it's legumes, it's grains. It's also a multiple vitamin. Throw that in. And nothing else is part of it. There's no candy, there's no soda, there's no meat, there's no dairy products because those aren't necessary. Your average person who's eating meat, they weigh 35 pounds more than the person who's getting their protein from beans and grains. So it's a simple program. The savings, $26 billion per year. Diet quality dramatically improved using the alternate healthy eating index. And what you can do with that is feed more people. What you're going to find, though, that Coca-Cola and other companies, which, as Matt said, are so busy on this, they're going to say, oh, but you're telling us what to eat. You're being patronizing. And what we have to say is, wait a minute, we're giving away free food. And the food we're going to give away are the foods that your kids need to have on the shelves. And those are simple fruits, vegetables, whole grains, beans, cheap food, healthy food, food you're proud of.
Yeah, so Mr. Arthur, that it seems like there's room for additional conversation outside of this forum on that, and I'm sure you all have been discussing that, you and the congressman and in the subcommittee. I think those are important points to think about. What's your impression?
No, absolutely. I mean, we're open to any and all conversation on this. In fact, in the earlier this year, the House Representatives recently passed the Farm Bill, and there was a variety of different amendments that were introduced addressing SNAP. Some of them were successful, other ones were not. But there's two main ones I want to highlight. One amendment that was brought up was talking about how the SNAP program can be used to purchase, some meals like rotisserie chicken, for example, a source of protein, which families would greatly appreciate. Other one was, an attempt to try to, restrict soda from being purchased. Not, unfortunately, that amendment failed. But the point I'm getting at is like we're open to any and all conversations on this because we understand every individual and every family is very unique and very different. There's different dietary needs. There's different, circumstances. There's also, ongoing issues in regards to access issues in rural communities and urban centers and our suburban areas. So there's a variety of different things that are that can be true at once. So it's important that, keep in mind and consider all the factors that are involved in this. So our door is always open in regards to having conversations about this.
That sounds great. We're going to have to move on shortly, not quite yet, but I just want to touch on the definition of nutritional assistance. From a legislative perspective, if we renamed SNAP to, let's say, SNOP, S-N-O-P, Supplemental Nutrition and Outcomes Program, and tied its funding to measurable health improvements in the population, would that change how Congress views its budget in this area?
Yeah,
Mr.
no,
Arthur.
it's definitely something worth, considering and having conversations about. I know one thing in particular that has been getting a lot of buzz around the halls of Congress these days. It has to deal with, how to access this data, like how to compare and contrast the data and everything. So there's been a lot of ongoing conversations about how to utilize electronic health records, for example. Like how can you use that to compile data? How can you utilize that information in a timely and effective manner? So, for example, one of the things that I'm currently researching and getting myself more educated on has to deal with the National Center for Advancing Translational Sciences over at NIH, and they have a very unique database called the National Clinical Cohort Collaborative, where they're taking electronic health records, for example, and they're using it to compare and contrast data sets and giving it to researchers to see how they can go about on a variety of different things. Right now, they have three portals available. One is talk about like long COVID, another is about renal disease, and the other was talking about a variety of different cancers. But there's conversations within NCATS and NIH about how to expand it for chronic conditions. So I think there's definitely an opportunity to compare and contrast and look at the data sets on that to see like, oh, we're noticing, for example, currently under USDA, there's 22 states that have SNAP waivers for different products can be purchased under SNAP. So how can we compare and contrast those states to states that don't have these waivers? What are the health outcomes, and how can we, direct policy from that?
Sure. Well, thank you very much. And just so for everyone out there, we realize some of you may be thinking, well, why isn't the state of Maryland on the panel? Why don't we have a representative? That would have been nice to have them here. And I just want to let everyone know that MedChi has worked really, really hard to try to get someone from the SNAP administrator, the Maryland Department of Human Services, to join us today. We're a little unique in Maryland. Health Department does not administrate SNAP. It's the Department of Human Services. And they have chosen not to participate. We have bent over backwards, quite frankly. And so we thought it would be helpful to have them there. I assume you would think so as well, since most of you are Marylanders. But anyway, I just want to let you know we have tried. We have really tried. And we'll keep trying to get them in conversation. You'd think that everybody, state and a private level, believes in good health, good nutrition for good health. So just they have declined. So we're going to move on. Good food, better health, lower costs. It's a prescription we all can get behind. And let's hit the definitions. Let's make sure we're all talking about the same thing. So these are generally accepted definitions of whole foods and examples. I realize we have some folks on the panel that promote more specific, narrower definitions in diet, and we're not saying they're right or wrong, but this is generally what's understood by what are whole foods. Whole foods are natural, unprocessed, or minimally processed foods that remain as close to their original state as possible. While some processing is needed for safety or convenience, like freezing or washing, the goal of eating whole foods is to avoid foods that have been refined or had additives introduced. They contain no added ingredients like sugar, salt, or fat, and retain their natural nutrients like fiber, vitamins, and minerals. For examples, we all know fresh fruits, vegetables, nuts, seeds, and unprocessed meats. So real food, real nutrition, real health, and we'll move on for a little. We'll hone in on some of these in the next slide. So some examples, because not everyone on the webinar may be physicians or maybe aren't really aware of all this. So on the right, you've got your raw potato is a whole example of a whole food. Basic example, you got minimally processed, bag of frozen plain broccoli, cleaned and frozen. Then you got the highly processed. I love the folks I run into, colleagues, some of them, you'll all laugh, will say, potato chips are just potatoes. That's all it is. Well, they're highly processed. Their potato chips are refined, the oil, salt added. So on the left, we've got fruit and vegetables, fresh, raw, or steamed vegetables and fruits, whole grains, brown rice, oats, barley, and quinoa. We've got proteins, fish, poultry, eggs, and lean meats. We've got legumes and nuts, beans, lentils, walnuts, and almonds. So you choose whole, you eat well, you live well. That's what we want you to take away. On to the next slide, where we bring in our panelists for the Good Health Blueprint. You can see we're going to take these points individually. Hopefully we can get through all of them with our with the two doctors, Nathan and Bernard. So nutrition is primary care. Chronic disease management is impossible without a diet-centric medical approach. Dr. Barnard, lead us off on that concept, that belief.
Nutrition is obviously central to primary care. Let me come back, though, briefly to the question of what processed foods are. And the reason that I want to get into this a little bit is that when we talk about, I think the slide that you showed is a really good starting point. But at Harvard University, researchers in 2024 wanted to see which processed foods were drivers of cardiovascular disease. And they found that out of about 10 different foods like processed cereals or processed meats and so forth, there were actually only two that were the big drivers of cardiovascular disease, meaning heart disease and stroke. And those were sodas and meat products. And when you took those out of the equation, all of the other processed foods were not a problem. And in fact, breakfast cereals, for example, which are sometimes get a finger of blame pointed at them. Breakfast cereals are actually the FDA's vehicle for folic acid fortification. So we don't want to be banning those cereals. Yes, they're processed, but the added ingredients are things that are going to protect an unborn baby. We don't want to be knocking that out. The processed fruit products and so forth, these are not bad. So processed foods, I think, is an overused term, I have to say. So when
ultra processed foods
and ultra processed as well. Yeah,
yeah.
What I'm speaking of is the word ultra processed came from the NOVA rating system, and it's popularized that term. And there are about 10 different categories of foods, and of those 10, only two of them really are big drivers of cardiovascular disease and diabetes. And by far, the animal-based processed foods, hot dogs, sausage, bologna, those are the biggest drivers. Second biggest are the sodas behind them. But things like breakfast cereals, breads, plant-based fruit snacks, and so forth, those actually reduce all those risks. So we're trying to get our patients away from this sort of naive, popularized view that ultra-processed foods are all terrible. We've got to ban them all. And if we could just define them and throw them out of our diet, we'll be doing better. If you focus on the two bad ones and leave the good ones in there, we're going to be better off.
Well,
So
if I
doctors
might
can play a
engage you
helpful
on
role there.
that for a moment, Dr. Barnard. I believe you're saying, I don't want anyone to misunderstand it. What you're saying is not necessarily that all those sugary cereals, some of them have tremendous sugar in them, are great for people. You're just saying they're not, the two worst offenders are the ones you've discussed.
No, that's not what I'm saying. Let me be
Okay.
clear. Let me be
Because I'm
clear.
familiar with the Harvard study, and the issue is not that all of these others are necessarily good for you or great for you. It's just that those two that you mentioned, those categories, are especially bad for you, tied to
No,
most
well,
of the
no.
disease. Uh-huh.
In the Harvard cohorts, the nurses study one, nurses study two, and the health professions follow-up study, they tracked people to see who developed diabetes, who developed cardiovascular disease. And the more cereals you ate, just the whole group, and that's everything from organic oatmeal to Frankenberry, the whole group, your risk of these conditions diminishes. Now, you're right that sugar is sometimes added. If you take, say, Kellogg's Frosted Flakes, it's got 12 grams of sugar added. Each gram has 4 calories, so that's 48 calories worth of sugar. That's trivial. The issue with sodas is that sugar dissolves into it. And if
Sure.
a person who has 3 cans, 12-ounce cans of soda has 117 grams of sugar they've consumed that day. So the incidental sugars that are added to foods here and there are unimportant and trivial and are used by the body for energy or for storage as glycogen. But
Thanks for
sodas
that
are a completely
clarification.
different issue.
Thanks for that clarification. We appreciate that
Sure.
emphasis. Well, we're going to stay on that then, and we're going to move to Dr. Nathan on her thoughts about what Dr. Barnard has opined, and then I'd like to get to the items on the slide if we can. Dr.
So,
Nathan.
just based on the conversation the two of you had on, defining ultra processed foods, I think it's really important to recognize that it's the eating patterns over time that really matter. Once in a while, if you have something ultra processed, it's okay, right? But if you have it day in and day out, if I were to have like 5 cups of Kellogg's Frosted Flakes every day, that's not good for me. Just like I would have 3 cups of sodas every day. So I think eating patterns really play a big role. Recognizing that and really helping the the people who you are like in primary care, your patients, uh, having them understand that over time. And this is not something that can happen within one just one or two meetings. It's something that has to be reinforced, and primary care is a great place to make this happen. Uh, I wouldn't say that it is only the primary care physician's role to do this. It is a team-based effort, and that's when you really need more than just primary care providers or physician serving that role to emphasize nutrition in primary care.
Well, that's good, please follow up with this, Dr. Nathan. So how do we best convince patients to avoid foods that are unhealthy for them? It seems like a simple question, perhaps a simple answer, but it really isn't that simple. So what's a strategy you
Yeah.
use, and then we'll move on to Dr. Barnard to respond.
I think you really have to listen, listen, and listen. Like just be there, be present, listen to them. You have to recognize what their habits are, what they like to do, what their, the culturally appropriate foods are, and then try and work with them on those changes that you would make. Because most of the foods at base may be healthy. There are things that are added to it, or there may be things that they like which are relatively healthy. We can make it even healthier. So we work with a lot of patients from varied backgrounds, but generally um, lentils and beans and vegetables and fruits, all of this play a huge role in improving their diets. How they season it, how they have it may be slightly different, but really trying to understand the patient or the person in front of you is the key in making that change. I have to also say, doing it in a in a group medical setting or a shared medical appointment setting really helps because they learn so much from each other, and it really empowers them.
Thank you, Dr. Barnard.
Yeah, I agree with Dr. Nathan. The group setting is terrific. We're doing a study now with Blue Cross Blue Shield where we have 184 people who all have diabetes. They want to get better, average age 71, and they're split into groups of no more than about 20 people. And they learn from each other. They get so excited, and it rejuvenates you as a physician too. I have to say, to see people get better and feel empowered. But Dr. Wargotz, I think you asked kind of the most important question is how do you start? And it's important for the patient to understand how food affects them. So if they want to get their cholesterol down, well, which foods have cholesterol? Which foods have the saturated fat that elevates cholesterol? Or if they want to get away from diabetes, type 2 diabetes, which foods are packing that fat into the cells, causing insulin resistance? Once they know a few of those things, then you can design the diet appropriately. If we're working with an individual, we usually bring in the spouse or partner so that they plan out the diet together. But the doctor doesn't have to do that. The registered dietitian can do it. And if you don't have a dietitian in your office, there are plenty of them that will work by telemedicine and would love to partner with you.
Thank you both. And we always have to remember, right, that we're not going on the street dragging these people into our doorway. These are people that are voluntarily coming to us for help, coming to both of you because they want your help. So you've got already a willing audience. Now, whether they're willing to eat lentils or give up this or give up that, that's the tough part. But they're already in your doorway. And so it's really how you apply your knowledge and your approach to the patient that will make a breakthrough or not. So we're going to go down this list real quick because we're closing in on our final 15 minutes. So the knowledge gap is a policy failure. Physicians must be formally trained and financially reimbursed to provide nutritional counseling. We've talked a little about the education side. Fiscal accountability. Federal programs like SNAP must be aligned with clinical science to stop subsidizing the next healthcare crisis. We've talked about that. And we haven't talked a lot about this, and we're not going to today. It's just not enough time, but wanted to get it out there because with some it's controversial. I don't think with anyone here it is, but I may be wrong. Food as a right, not a luxury. Access to disease reversing whole foods is a matter of public health priority and is national security. I put that in there because that's how I feel. And so I'm hoping all of you, we're not going to have time to discuss it, unfortunately. But a healthy nation starts with real food. So let's build a blueprint together. And let's move on to the next slide. So we talked a little about, stakeholders, missing stakeholders. And again, it's really a soft criticism, but it's a criticism nonetheless, that, as we have these discussions at MedChi about nutrition and healthy food, we really call on the DHS to participate. We need to understand what they're thinking in the program because there's a tremendous cost of inaction, clinical health outcomes. It must be supersede political hesitation. There has to be direct accountability for how state-administered benefits impact long-term chronic disease management. It seemed obvious, doesn't it? Dr. Nathan, Dr. Barnard, do you want to comment just briefly on this? Am I alone here? Dr. Barnard.
I have to say, politics really enters into every aspect of this, unfortunately.
Well, I don't want to drag you into that, but we're all on the same team, right? We all want good nutrition, good outcomes.
There's no
I
question.
would say that they would definitely want the same. They would want good outcomes and good nutrition. There is a lot that is currently, occupying their immediate time with all the changes in SNAP attribution
Sure.
and the work requirements. And so I think that there's a lot happening
All right. Well,
that
let me engage
needs
Mr.
urgent.
Arthur on this because he and I have talked about this. I've been working with his office for a number of years now to try to get support for modifications in SNAP and how folks are educated in SNAP in Maryland. And we've reached out to the state, Mr. Ransom and I. We've tried a number of times. So, Mr. Arthur, I hate to assume anything, but I assume you hear my frustration. You've got some frustration. Congressman has some frustration. So we'll leave the two good doctors out of this discussion.
Yeah, no, absolutely. And no, I mean, in regards to SNAP in particular, I mean, it's a team effort. I mean, the 50% of the cost comes to state, 50% comes to federal government. So it's important to have all the stakeholders and people who administer the program come together and, talk about, what's going on, what are they seeing, what are some of the struggles, what are some of the successes, and then come together in a collaborative effort to, to address these issues. It's definitely frustrating. I mean, I think Maryland, for example, really missed an opportunity of a lifetime with the Rural Health Transformation Program, for example. One of the pillars in there was talk about make make rural America healthy again. And one of the pillars associated with that was talking about nutritious foods. And one of the sets that Maryland could have applied for and get additional dollars from that program was about implementing a SNAP waiver. And unfortunately, the state didn't do that. So no, I get your frustrations with that. We're frustrated with some things too, but I think it's important to still have an open door policy and have conversations. We may not agree on everything, and we want to make sure that nutrition is not a politicized or partisan issue. And again, like I mentioned earlier, we're working with Congresswoman Debbie Wasserman Schultz in regards to how the FTC is
Sure.
cracking down on marketing for ultra processed foods, for example. So we want to have these collaborative conversations.
Sure. And we continue to, I sound frustrated, and I am. But MedChi continues to reach out to all the state agencies to discuss matters of health to the citizens of Maryland and the region, and we'll continue to. We have good relationships with them. We'll continue to, but we definitely need to get them to the table on the SNAP discussion. So the political absence has clinical consequences. That's what we're talking about. Let's move on. And so the major takeaways, we're going to go through these, and then each of you will have an opportunity to close with a few remarks. It's amazing how quickly an hour goes by, and we have 6 minutes. So I'll make this real quick. Major takeaways: health above politics. Clinical outcomes and reversal of chronic disease are human rights, not political bargaining chips. Immediate action required. Federal and state policies must align with the food is medicine evidence presented today. Physicians as leaders. Physicians are ready to lead this change. They only require the legislative will to support them. In direct accountability, we must continue to demand that every stakeholder, including our state agencies, prioritize nutrition as the most effective tool for fiscal and physical health. So, food is medicine, policy is power. Together, we can build a healthier future. Dr. Barnard, take it away for a couple of minutes.
Okay, just really quickly, kind of where we started was talking about how there are lobbyists from Mars or Coca-Cola or others that are lobbying. They're not the only ones. Maryland has a huge chicken industry. They all want to be part of SNAP. The meat industry, the dairy industry are the political pros. It's incredible.
Good
And
point.
so we have to realize that those are the political realities that we are dealing with. And how do we deal with it? It starts with education. Once we understand what is it that's driving your cholesterol level, what's driving your body weight, let's take those in hand and let's decide that SNAP should not be just a grocery store free card for anything you want. It really should be to support healthful foods. And the people who are at the greatest risk if we decide wrong are those children who are now 2, 3, 4, 5 years of age, learning about what food means. Because in a blink of an eye, that's going to be a 50-year-old man or woman on your exam table with heart disease. And they say, well, this is what
Thank
I
you.
grew up eating. We need to change that.
Thank you very much. Dr. Nathan, a couple of minutes to close. What's on your mind at the end of this session?
I think that we need to prioritize research that supports more of, like social and environmental aspects of health, not just on, like, say, one molecule or one specific area, because even nutrition cannot just stand on its own, right? There's so much more where people live, where they work, where they play, where they learn. So you really have to keep all of those factors in mind when we are bringing about evidence-based scientific methods, and then we can use that clinically every day, right? Definitely, there's lots of different conflicts in the industry. We have to keep that in mind. But again, that needs to be the people who are going to be, the conflict of interest needs to be looked at is not for the SNAP recipients per se, it's for the industry, all of them, so that everybody's
Yes.
affected the same way. So
Thank you.
that's what I would like to say.
Thank you. Mr. Arthur closes with a couple of a minute or two on your thoughts as we move forward regulatory wise.
Yeah, no, absolutely. First, I just want to say thank you, Dr. Wargotz and Dr. MedChi thank you, MedChi, for organizing this. This was a fantastic conversation, and I think we need to keep having conversations. I know sometimes it's uncomfortable, and sometimes we have conflicting interests and everything. But like I mentioned, like we're open and willing to have conversations with anyone and everyone about these issues, regardless of where they're coming from and everything. We want to make sure that we have a healthy population. I mean, talking about, children, for example, I mean, back in the 1960s, less than 5% of children were obese. Today, it's more than 20% of children are obese.
Right.
So clearly we're having some
Gotcha.
type of chronic crisis going on. So we need to, put all our brain power together to, and put politics aside in a lot of regards, to just find out ways to, make sure we can, sustain the life of children, make sure that we don't have a crisis moving forward.
Thank you very much. Well, it's science, compassion, accountability, and action. And the time to act is now. Sorry, folks in the audience, we don't have time for questions from you, but I want to thank our esteemed panelists, Dr. Neil Barner, Dr. Aruna Nathan, and Mr. Matthew Arthur, and all the MedChi staff for all their support and participating in this. We try to cover a lot, as you know, with me in MedChi and in the audience in an hour. And I think we all appreciated your time and your expertise. The next MedChi lunchtime webinar, Getting Ahead, Gaining Access and Improving Your Physician Practice Financial Health. As you know, those are acronyms for different programs from CMS, the federal CMS, and these are ways that you can get compensated a little better for the work you do and for the patients that you see. That's Friday, September 25th, 2026. You won't want to miss that. Thank you all so much. I want to thank our sponsor once again, Unity Insurance, and Ron Kendall, Executive Vice President. His information is in the question and answer. So thank you all. This is Eric Wargotz signing off from MedChi, and thank you all very much for joining us. It is 10 seconds away from 1 o'clock. There we go. Thank you all. Safe travels. Enjoy the weekend. Bye-bye.